all of you. So from the MCNS, there are only two announcements that upcoming EC committee meeting will be on the 12th of January, and our early bird registration for the MCNS 2026 February 20 to 22 has started, and early response is good. So means I myself are getting too many inquiry for that. So I think it will be a great conference. So as early as possible, get registered for the conference. So that is a sincere request. And I hand over to Dr. Sandeep sir to proceed with the
Yeah.
webinar.
Yeah. Thank you, Dr. Sarang, and thank you, Dr. Shiv Shankar, for this opportunity to moderate this today's webinar, which is going to be on functional neurosurgery. So even though everybody is not practicing functional neurosurgery, but one should know about the indications and how about it. So, and today we have fantastic celebrity speakers as well as panelists for the webinar. So for today's webinar, we have an international faculty, Dr. Kazuki Yamamoto from Japan and Dr. Kanchan Pillai from Mumbai. And we have three speakers. So I would like to introduce Dr. Kazuki Yamamoto for this to this August gathering. Welcome, Dr. Yamamoto. Uh, Dr. Yamamoto has done PhD and is a neurosurgeon specializing in stereotactic and functional neurosurgery. Currently serves as a director of the Functional Neurosurgery Center at Shonan Fujisawa Hospital in Japan. He completed clinical and research fellowship in stereotactic and functional neurosurgery at Toronto Western Hospital, University of Toronto, following prior fellowship at Tokyo Women's Medical University. And Dr. Yamamoto obtained his MD from Sapporo Medical University and his PhD from Osaka Medical and Pharmaceutical University. And today we have another faculty in the form of Dr. Kanchan Pillai. Madam is a consultant neurologist and movement disorder specialist at Nanavati Max Hospital in Mumbai. She has numerous publications in various national and international journals. And we have three speakers today. First one is Dr. Gurmeet. So maybe as I invite Dr. Speaker, I can introduce about him. So let's introduce Dr. Gurmeet Singh Sahani. He's a senior neurosurgeon and holding the position of Director, Stereotactic and Functional Neurosciences at Fortis Hospital, Mumbai. Along with the routine neurosurgical and spine cases, his special interest in functional neurosurgery led him to do fellowship in functional neurosurgery at Tokyo Women's Hospital in Japan and epilepsy surgery at Zudento Hospital in Japan. So he's the first speaker for the webinar. So I would like to hand over Gurmeet Singh to talk on DBS and listening procedures in movement disorders.
Yeah. Thank you. Thank you so
And
much.
first of all, sorry to acknowledge and thanks Gurmeet for connecting us to Professor Yamamoto. Thank you so much.
Yes. Thank you. Can you see me and hear me?
I can hear you.
You can't see
We
me?
can share the screen.
Yeah, you are seen, but your slides are not seen. At least share the slides.
Now, my face is seen, no? Yeah, so I will share my screen.
Yeah.
Yeah, just give me a minute. One minute. So, okay, is it visible, please?
Yes, it is visible.
Yes.
Good.
So, at the outset, I would like to thank MCNS, our own MCNS. I always like to be associated with MCNS in any way or the other. So, for allowing me to present here. And a special thanks to Dr. Yamamoto, Kazuki Yamamoto. So he and me go a long way. We actually were together in Japan for a functional training, and after which we became great friends and we talk very regularly. And really thanks to him, because it is night 12 o'clock there and he's sitting with us. They are about 3.5 hours ahead of us. And thank you very much, Dr. Yamamoto. With that, I'll start without further delay. I'm going to talk about DBS and lesioning in movement disorders. So here, in movement disorders, we expect the unexpected. Now, let me show you this patient. Now, this patient, as we can see, is having tremors. He is having bradykinesia, unable to turn, rigid. He is just standing in the way, and I'm not even able to take him ahead. Are you able to hear the sound of the video? Can anybody help me?
No, sound is not audible.
Okay, sound is not audible?
No.
Okay, so I don't know how to put the sound on with the screen share, because I can hear the sound. Can any of the team help me that how can I give the sound here to one screen sharing? Because my sound is full here. Okay, then I'll go ahead. If you're not able to hear the sound, that's also okay. Let's see. So here I was showing that there's a case of Parkinson's, and then we saw that he suddenly became better. Now, like magic, and there is a lot of smiles around. How did this happen? I will tell you at the end. But this was a case of movement disorder post DBS. Now, what is movement disorder? Movement disorder is abnormal movements. It could be voluntary or involuntary. There is so if there are movements, then there can be akinetic, rigid, or slow movements like Parkinson's, or dyskinetic movements, that is more movements like tremors, chorea. The anatomy here is mainly around the basal ganglia thalamus area. There are a lot of movement disorders, but I will mainly talk about 3: Parkinson's, tremors, and dystonia. Parkinson's disease is so named after James Parkinson's. So this is a chronic progressive neurodegenerative disease. Now, these all are very important. It is chronic, goes on, progressive, it keeps on increasing, and it degenerates the brain. So our treatment should be according. The incidence is 0.2 per 1,000 and prevalence is 1 in 500 person will have Parkinson's, mostly in 50 years of age, but 1 in 20 Parkinson's is less than 20 years. That is Parkinson's in young. What happens is there's degeneration of substantia nigra and dopamine is not produced. Now, what happens when dopamine is produced? Dopamine is a happy hormone. Whenever dopamine is produced, we are all happy and move around. And this is controlled by subthalamic nucleus, which tells the dopamine to the response to go down. Now, when dopamine is less, the subthalamic nucleus becomes stronger and we develop bradykinesia. Now, that's how the pathophysiology goes. So there are about 4 cardinal features: bradykinesia, rigidity, tremors, and postural instability. Now see this patient, a bradykinetic rigid patient. Now this is a case of this is Parkinson's in young, and he is a doctor himself. Now this is an old patient with tremors, unable to move, rigidity, freezing. This is an old patient. Now, conventional treatment is first we give dopamine, that is levodopa, and the other allied medications. But when there are problems, the indications which I will tell you, we think about surgical procedures, that is DBS or lesioning. Now, at what time should we think about this surgery? I always say that the Parkinson's is a 40-year disease, out of which when initially when the motor symptom starts and we give dopamine to the patient becomes really benefited and they are all happy like normal. But when the fluctuation starts or a dyskinesia starts, which is a side effect of dopamine, that is where we should catch. Now this is the area where the treatment should be done. So it is not an end of life treatment. That's what we need to know. Next is tremors. Now, tremors is rhythmic shaking movements. It can be hands, head, or the other part. So there are types are essential tremors, Parkinson's, dystonic tremors. Now, this is a case of essential tremors. You see that how the patient is writing; they're unable to write. Usually, uh, we don't think anything about these patients, and we just give them a certificate saying that you cannot sign in the bank. But this can be treated. Now, this is a case of dystonic tremor. So she has got tone which is high, abnormal movement, and then there is a dystonic tremor. The medication, so treatment is three-tier. First is medications, beta blockers, then Botox injections, physical therapy, and then comes surgery, which can be lesioning or deep brain stimulation. Next is dystonia. Now, dystonia is involuntary muscle contractions. There can be pain in that, and it can be hereditary or acquired or idiopathic. Now, you see this patient. Now, he has got this movement and of the neck. So, there's abnormal movement of the neck. There's cervical, there's facial. His shoulder is up on the other side. So this is an oromandibular, which is very common in old patient, which we see. So this is a patient with hemidystonia on one side. He's got cervical, hand. We usually get scared, and this is a generalized dystonia. Now, again, a three-tier treatment: medications, Botox injections, and Botox helps in some patients and some don't, and then the effect goes off. And then we land up with surgery, either lesioning, that is radiofrequency lesioning, or deep brain stimulation. Now, what are the targets that we look into? So we look into a VIM thalamic nucleus for essential tremors, a STN or subthalamic nucleus for Parkinson's dystonia, a globus pallidus or GPI for Parkinson's dystonia, and VO nucleus for focal dystonia. Now let's go to our topic, deep brain stimulation. Now there is a level 1 evidence that DBS helps, DBS improves. But appropriate patient selection is important. It is not an end-of-life care. So DBS was approved first in 97 for tremors and Parkinson's, and then STN DBS in 2002, then 2003 in GPI, and an early DBS is approved in 2016. Now, what are the indications? First is the diagnosis should be very correct. So there are two types of Parkinson's. One is idiopathic and other one is Parkinson's plus. So it doesn't help in Parkinson's plus. So all the patients who have got benefit with Syndopa initially or Levodopa, those people will benefit. So the motor symptoms after taking Syndopa should be at least there is a UPDRS score which increases by at least more than 33%. Then only he becomes a candidate. Now, when we should do it, there's a simple rule called 5:2:1. That is, if the patient is taking 5 doses of Syndopa per day, in which the patient has got a 2-hour of off period in 24 hours and 1 hour of dyskinetic movements, which is a side effect of Syndopa, then he is a candidate. He should not have cognitive problems for which neuropsychological assessment is done. And the upper age limit nowadays is taken as 80, but it all depends upon the functional age, not the chronological age. So let me take you to a tour of DBS process. Now, first, what we require is a stereotactic frame, which is very important. There are multiple frames available. What I use is the Lexel frame. The frame fixation is done under local anesthesia by giving a scalp block, and this is how the frame is fixed over the head. You can see once the frame is fixed, as we can see here in this patient, the patient is taken to a CT scan where the frame is put on the adapter after putting the indicator, and while we do a CT scan using this indicator. Following which we have to get our site correct or the target, for which first we get the ACPC line, that is the anterior commissural posterior commissural line, and then we decide our target, get our entry, and get 3 points, that is the X, Y, and Z points for the right STN and the left STN, as you can see. Now these points are important, and this is our target, which we will reproduce it on our frame. Now, after getting this, we take the patient back to OT, do a draping, as you can see here, with a C-arm on it, and the patient's face should be visible so that we can examine the patient. So this is an awake surgery for all benefit. Then, for the surgical procedure starts, we put the arc of the frame on the patient, and then we put something called a star drive, which helps us to guide our electrodes inside. It has got two major features, which is the array tubes called straight tubes, and it has got a micro drive also. Now, following which we do the craniotomy of the patient at the burr hole at the marked area, and then we do the microelectrode recording. Now here I wanted the sound to be, because that sound is what will help. So we are able to hear the sound of the electrode. I hope I could have shown you that. So as we go millimeter by millimeter inside, we are able to see the waves and the sound of these waves, which we can see. Now how is the sound of the STN is like rain falling on a tin sheet. जैसे पतरे पे पानी गिरता पट 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 पट, उसी तरह से sound आएगा. And that is how we come to know we are at the spot. Then is the clinical localization. This is a neurologist. So he is checking it after we have stimulated the patient. Now you can see that the patient's movement is quite good here. The third is, then after we find out, then we place the DBS electrode inside, slowly inside, and we check it by a C-arm process. So in short, what we did 4 levels of localization. First is the anatomical localization that we did on the MRI. Second is the physiological localization by the microelectrode recording. Third is the clinical localization by the neurologist when we stimulated the patient. And fourth is the radiological localization to see exactly that we are at the center. And then we get the correct place. After that is done, then the patient is taken under general anesthesia, and we put the IPG or the battery below the clavicle by tunneling it, as we do it for a shunt. Now, after that, we take a CT scan again, and we overlap it with in a system. So this is our Sure Tune system, in which we are able to see. Now this is our electrodes. This green thing is the subthalamic nucleus of the STN. This is the substantia nigra, the yellow, and that is the red nucleus. So this program is with an MRI, and they give us a real-time picture, and we can see that how our electrodes are inside, what is out, how much it is in, what position, and the programming, which is done by the neurologists later, it really helps them. Outcome, we see that there is benefit in all the features of motor features of Parkinson's, and also it goes to about 70 to 100% sometimes of improvement. And here we can see after stimulation, when the off phase of the patient reduces significantly and the patient doesn't have dyskinetic features. After 5 years also, it is maintained well, and there are economic benefits as the patient becomes better and back to work. I'll show some of the DBS cases fast. Now this is the same patient that we had seen before, and this is the post-op. Now he is the doctor, so he started it already, and he is better, back to work. See, this got old patient, Parkinson's, difficult to get up, unable to move. She's got this freezing. And this is post-operative. So this is when I had gone to the marriage of her son. It's difficult to know that she has Parkinson's. So this is another patient which we can see slow movement. This is post-op. Walking. This patient, so I've got all different features, unable to turn, and now he's post-operative walking straight and also walking backwards. This patient with severe tremors, difficulty in moving. So they all have shown benefit. So I can show multiple patients, but I will stick to that. This is after 3 years of DBS. So she's very good. So she's improved. Now that was deep brain stimulation in brief. Now I'll go to radio frequency lesioning. Now in radio frequency lesioning is usually done for patients with Parkinson's. If it is one-sided, or in Parkinson's, I will always feel that DBS is better because it's a bilateral disease. In essential tremors, the lesioning has got major benefit. There is the third thing is dystonia, where I feel lesioning is superior. Now this is the positioning. The positioning is a little different as compared to the other. Now here we don't do microelectrode recording. This is the main electrode only we are putting, and I'm going slowly inside. Here also the sound will tell us this, but I don't think that you are getting the sound of my video.
Dr. Gurmeet, sorry to interrupt,
Sir.
but I will have last 2 minutes so that
Oh,
we
last
can.
2 minutes, it's done.
Yeah,
It's done.
yeah.
Then in last 2 minutes, it will be done. In 2
Yeah.
minutes only remaining. Okay, so this is a so this is how we give the stimulation, and at 70 degrees of 40 seconds we do the lesion. Now this is the case of essential tremors that we can see. This is intraoperatively when I am operating on one side. We are operating on his right hand. I am operating on the left, and this is immediately post. So this is hemibalismus chorea, and this post-op day 1, where we can see that his movements are absolutely normal. Abnormal movements of brain. Case of dystonia, I'm just rushing through so that she's improved, but there are some symptoms remaining. Case of Parkinson's, severe movement, and this is post-operatively. And that is my last slide. Okay. One little thing I'll tell you before I close. Now, this is also essential tremors. In emergency procedures also, radiofrequency lesioning helps. Now, see, this is the patient which I will tell you. This is a patient of emergency which came with injury to the leg because of tremors. And we did that. They were not able to extubate her or take her out of the ventilator. And after the lesioning procedure, she became. Now, that's what I wanted to show. That's the last slide. So in India, the prevalence of movement disorders is very high. If you say it's about 6.5 to 10 million patients here in India, but the amount of surgeries which are happening throughout India is about 500 and 600 annually, but whereas in US is about 4,000 DBS happens annually. So my take home message is that every neurosurgeon should learn and practice these procedures because they are very, 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 very rewarding, and they have got good outcome. Like you see this patient, Parkinson's, and after that it's dancing. That's all. Thank you. Thank you so much. Thank you.
Yeah. Thank you so much, Dr. Gurmeet. It was a wonderful presentation, right from basics to, advanced, how every neurosurgeon should know about it. So we'll be having discussion at the end of all the
I will stop my
talks.
screen share, please.
Yeah.
One
Yeah,
minute.
you can please
How should I stop that?
stop sharing. Till then, I invite a second speaker who doesn't need any introduction to this gathering. This is none other than Dr. Milind Devgakar sir, who has a vast experience in functional neurosurgery. He has spent more than 2 decades in the United States of America practicing functional neurosurgery. Now it's a fortune he's back to India since last few years, and presently he's working in Institute of Neurosciences, Kolkata. He's heading the functional neurosurgery program there. So may I request Milind sir to please share the screen and delivers his talk on DBS in non-movement disorders. Sir, unmute करू शकता sir.
Can you hear me now?
Yes, sir.
Okay. This is a very
Please
good topic
share
for
the screen, sir. So your screen is not, slides not seen.
yeah, I'll do that. It's always complicated to do that. Can I put the Okay. Can you see the slides?
Yes, sir. Yeah, we can see now.
Yes, sir. The slideshow.
Okay. Thanks, Sandeep. And
Yes.
it was a wonderful talk, Dr. Gurmeet. You given Sandeep, you have given me a non 15-minute talk. Non Yes, cannot be.
Thank you. You're correct, sir. 15 minutes is not enough. Thank you.
Correct. But I will try to touch on the important indications, and these are my conflicts of interest, not applicable to this talk. Before I start talking about it, there are two distinct differences between DBS for tremors, Parkinson's dystonia, and other DBS indications. And the first one is whenever a solution looks for new problems, it sometimes is not as efficient. We had DBS, we knew how to modulate the brain networks, so we started applying it to other conditions, and sometimes the results are not as spectacular or as black and white as motor indications, because these are all disorders which are sometimes multi-circuit disorders, and sometimes they are difficult to quantify, and they have different other surrounding inputs which cause these disorders. And second one, as I said, movement disorders outcomes are much more objective. There is tremor, there is no tremor, but that doesn't happen in chronic pain. That doesn't happen in TBI. That doesn't happen in depression. So these two caveats we need to keep in mind before we start discussing the non-motor indications. And I roughly group them under disorders of limbic system, disorders of consciousness, disorders of cognition, disorders of synchronization, neurorestorative indications, and other disorders. I cannot talk about all of these. So what the one in bold, disorders of limbic system, these are psychiatric disorders, and we'll talk briefly about depression, OCD, maybe touch on addiction and some other disorders. Disorders of consciousness, primarily DBS and TBI, traumatic brain injury. Disorders of cognition, dementia, and the attempts at DBS and dementia are all futile. So I would not recommend for anyone to do DBS for dementia. People have done mammillary body DBS and people have done fornical DBS, but no one has really shown any benefit. Disorders of synchronization. Now, there are two big classes in this. One is epilepsy, as we all know. This is primarily disorder of synchronization, and the second is chronic pain or central pain syndrome. Once you get thalamocortical dysrhythmias, you start getting centralized pain, and so you can actually desynchronize brain by doing a DBS in the pathways of synchronization. Neurorestorative disorders are done. Some of the ones of dentate nucleus DBS in stroke rehabilitation. I'm not a big fan of it because it kind of offers just a push and doesn't do much. And other disorders, then We can talk about autism and things like that, but I think we still don't know the basic science about them. So thinking about putting a lead in someone's brain where we don't know the basic pathology is probably not a good idea. Coming to disorders of limbic system, if you look at the Pape circuit, you see the nodes, you see the pathways. The frontothalamic pathway is the biggest pathway. You modulate it by modulating anterior capsule, and you will get the desired outcome. Or if you don't want to go there, you can go to anterior thalamus, or you can go to dorsomedial thalamus, or you can go to ventral striatum, or directly to orbitofrontal or prefrontal cortex. So these are all the salient points which you can modulate. We'll talk about OCD because that was the first indication approved for DBS, and we started doing DBS for psychiatric disorders in Cleveland Clinic in 2005, 2006. Initial reports for DBS for OCD came from Bart Newton. Bart Newton was the one big driver behind the psych DBS. And internal capsule striatum were both targets for the most favored targets for all these DBS. There are more than now probably 500. These are old slide decks, but patients with DBS implants, I think we have in Cleveland Clinic and OSU put about 40 odd DBS for depression and OCD. Later on, we shifted to the lesioning for OCD because that was much more easier for us. We done some STN DBS also for OCD. Overall outcomes, you see about 40% improvement, reduction in drugs, about 40 to 50%. These were one of the initial studies which basically gave it a US FDA approval under HTE, and that showed about 60% patient response in their YBOX scores. My first encounter with DBS for psychiatric disorders was in 2005 when we started doing this investigator-induced trial for DBS for depression, and Don Malone was the main guy behind it. Ali Razai was part of it, of course, and we did about 15 patients, and the target was in it, and good responder rate and good remission rate. And the results were out in 2007. Around that time, Medtronic started this RECLAIM study. And RECLAIM was the first randomized controlled trial of DBS for depression. And we were one of the major centers in it. And this study kind of, after 30 patients, shut down because the interim analysis showed that there is no difference at the end of 16 weeks titration phase if you do DBS or you don't do DBS. Similar study was started by Andrew Lozano's group in Toronto for the area 25, Helen Mayberg's area, by Abbott, and the study showed the same thing, and that study was also shut down. Now, when this study was shut down, we didn't know what happens in long-term open-label stimulation because we followed these patients. I think we had about 9 patients from our center in Cleveland Clinic in this study, and when we followed them over a period of 5 years, we see persistent reduction in depression scales. And so long-term outcome in DBS for depression is good. Short-term, you may not see such a big difference. But I think now we are way beyond doing another randomized controlled trial for depression. This was the trial done by Bob Gross and Lozano, and this was the subcallosal cingulate area 25, Helen Mayberg's area. Moving on to surgery for addiction, anorexia, obesity, bulimia. Addiction, we had done 1 patient in OSU. We had done 3 with obesity. Obesity is considered as food addiction. So the same target, nucleus accumbens. You put a DBS in that and patients will improve. We had an IHR01 for that. 1 patient really, we published it, but 1 patient really lost weight and stayed sustained weight loss for a few years, but the other 2 did not show any specific weight loss after the initial phase of the study. So we don't know whether it really works. Anorexia, we had done one patient anorexia, and she responded pretty well. So all these psychiatric disorders, if you go to nucleus accumbens, which is back, we don't know what we are stimulating. We are stimulating nucleus accumbens, we are stimulating ventral striatum, we are stimulating anterior limb of internal capsule, but we are stimulating the frontothalamic peduncle, the major white fiber outflow. And if you stimulate that, most of the psychiatric disorders will get better. Disorders of consciousness, done DBS in persistent vegetative state with not very good results, but the one study that we did again in Cleveland Clinic back in 2006 was the minimally conscious state DBS, and this was published in Nature, and we put in a DBS in interlaminar nucleus of thalamus. So interlaminar nucleus of thalamus is an area of very diffuse, vague nuclei which get inputs from every part of the brain and has output to all parts of brain, and a major thalamocortical outflow which is a part of arousal circuit. So if you put a DBS in that and you kind of increase the output, you're not inhibiting anything, you're increasing the output of thalamocortical outflow, patients will get awake. And I think we did 4 patients in it. And all of these patients showed sustained improvement in arousal. The first patient was amazing. 18 years after head injury, was in minimally conscious state for 18 years, and he completely woke up. And when he had an accident in football stadium, so he asked what was the result of that football match. So his memory also came back. So the other 3, 2 did very well. All of them had improvement in swallowing, but arousal was not that improved in the remaining 2 patients. One patient did not have any improvement. But I think this is a good target to go to in patients who are kind of towards the 6, 7, 8, 9 months, and they're minimally conscious, they're kind of plateauing. I sometimes think we can even do outside leads and stimulate for 3 months and pull the leads out, or stimulate for a month and pull the leads out. This is a very good target and very good indication to study more in setups like ours, where long-term care is a problem. Disorders of synchronization, epilepsy, Sante trial, everyone knows anterior thalamic nucleus DBS. Most of the people are doing CMPF DBS for basically the drop attacks, works beautifully well. The difference between VNS and anterior thalamic nucleus DBS is sometimes patient can get completely epilepsy free with DBS, never with VNS. So in my mind, DBS is a better option than VNS. Coming to pain, we've done a lot of pain DBS. I've done all these 3 targets. There are 3 targets. Thalamic DBS, thalamic is VC and CL. CL is nucleus centrolateralis, and VC is ventralis caudalis nucleus. That's the sensory nucleus of thalamus. Most of the neuropathic pain or deafferentation pain or CRPS, you go to thalamic targets. PAG and PVG, this is periaqueductal gray. That's the seat of endorphin in brain. So you stimulate that and endorphin release goes up multifold. So this is very useful for chronic intractable somatic pain. And nucleus accumbens DBS basically works on the medial pain pathway and takes away the affective component of the pain, though the pain remains. The pain doesn't go away, but patient doesn't feel bad about it. This was our initial experience with VCCL DBS, 9 patients. We used to do bilateral CL because we want to modulate the whole brain's pain perception. And then on the contralateral side, we'll put a VC lead in the area of pain. 6 of these patients were face pain. 1 was CRPS of the hand, and 1 was heavy body pain. Face pain patients did very well, and some of these patients are still in contact with me. They're still completely pain-free. So we have this almost 20 years follow-up on these 9 patients, and almost half of them still have very, very good pain relief. So DBS for chronic pain is a good option. This was one of the trials that I was part of initially. This was Andre Machado's trial about nucleus accumbens DBS for post-stroke pain. Because thalamic pain syndrome, you cannot put a lead in thalamus. Thalamus is already destroyed. So in that case, you can go to nucleus accumbens where the perception of pain goes down. That's pretty much about it. I thought I will stay in time, so we have time to discuss. There are a lot of other indications which are there, which can be talked about. But I think uh, it's better that we start with something where we have data on randomized control trials and where we have data on large patient groups, and not go to very adventurous indications. Thank you very much.
Oh, sir, thank you so much for finishing before time so that we can have more time for the discussion. Thank you, sir. So may I request our third speaker for the webinar, Dr. Aniruddha Bhagwat. He has done MCH neurosurgery from Bombay Hospital in 2020, and after that he has done fellowship in stereotactic and functional neurosurgery from Rockefeller Neurosciences Institute, West Virginia, by 25. And right now he's working in Dinanath Mangeshkar Hospital, Pune, as a consultant functional neurosurgeon. So may I request Dr. Aniruddha Bhagwat to share his screen, please? So I think Milind sir was the same place where Dr. Aniruddha was trained.
Yes, sir. Is the screen visible, sir?
Yes, it's visible.
Okay. So my talk is going to be a little like a continuation of Dr. Gurmeet's talk because he spoke about lesioning procedures. And basically what I'm showing here is a new way to do the same lesioning procedure. So this is MRI guided focused ultrasound surgery, which has been well established in the world for almost 10 years now and has been available in India for the last 4 years. There are some 3 centers in India right now which offer this treatment to patients. So this is going to be the outline of my talk. I'm going to talk about explain the technology, some brief history, significant milestones, its efficacy in FDA and CE approved conditions, and some upcoming indications. So essentially, it is like a gamma knife, we can say. It is a technology where sound energy is used to create lesioning or ablation within the brain through an intact skull. And so high frequency sound beams are used, more than 20 kilohertz. They all concentrate at one particular point. Where they concentrate, they cause rise in temperature. There is a, so it is shaped like, is my cursor seen, sir? Is my cursor
Yeah,
seen?
it's in.
Okay, so it is all the arrows, it is a hemispheric transducer, and the hemispheric transducer at the focus of that hemisphere, all the sound beams concentrate, and they create an elongated focal spot where the temperature is high. There are almost 1024 beams that are focused. This allows more, accuracy of targeting. The temperature rise, anything above 53 degrees Celsius causes ablation of brain tissue, irreversible cell necrosis. And MRI thermography, why it is called MR guided focused ultrasound is because MRI thermography allows us to actually monitor the spot in real time. So you can see that we can see the orientation of the thermal spot in all 3 dimensions, and we can also get a map of the temperature rise. Of course, the most important thing about this technique is that it is an incisionless technique. So this is just a short video that explains how this technology works. As you can see, this is happening inside a MRI machine because it is MRI guided. And you can also see the helmet shaped transducer. So this is what the transducer looks like. It is a helmet. This is an entirely detachable assembly. So the MRI can be used for diagnostic purposes at other times. When we use high intensity sound beams, it causes a rise in temperature and produces lesioning. And when we use low intensity sound beams, we can produce non-lesional effects such as neuromodulation and blood-brain barrier opening. When the patient is made to sleep, now we have not shown a frame here, but we usually use a CRW stereotactic frame to achieve head immobilization. And you can see the patient's head was shaved, and this is how it lies within the hemispheric transducer. The entire transducer is filled with water. We decide what the surgical target is going to be in the particular patient. All the sound waves are sent out. They all concentrate at the focal point, and it produces a focal lesion. This entire process lasts about 1.5, maybe 2 hours. And at the end of the 2 hours, the patient is completely symptom free. So it is a daycare procedure. And the mechanism of action is, of course, thermal ablation. There is usually intense thermal heating at the focus. If you can see here, it produces this kind of well circumscribed spot at the exact target. And there is in the center, you can see a very dark zone, that is the central necrosis. This is surrounded by cytotoxic edema. So this is going to develop into the irreversible lesion. And surrounding it is a zone of vasogenic edema, which appears over 3 to 5 days and then disappears over 2 to 3 weeks, which can cause some reversible side effects. This is the great advantage. As you can see, if you compare the accuracy as regards the peripheral dose fall off, you will see that MRGFUS produces the most circumscribed lesions. This is a brief history of the procedure. It actually started from 1920s when sonar was first invented, and they found that fish in the sea were dying in the beam of the sonar. That is how they realized that sound beam can achieve enough energy to produce tissue destructive effects. And then they started investigating, of course. A very interesting point is that Professor Lars Lexell, before he went into gamma knife, he actually experimented with focused ultrasound. And this was his actual, first brainchild. He wanted to use focused ultrasound for intracranial lesioning, but the problem at that point was that the sound waves cannot pass through an intact skull, and so they had to do a craniotomy to allow the sound waves to pass. And so he found that extremely inconvenient. That is how he moved to gamma knife, because that is penetrating radiation. And then you, of course, have a long history of surgeons and scientists who experimented with technology. The most important landmark was in 1998 when some phase correction equations were described by Professor Hununen, which allowed the sound waves to be focused through an intact skull, and that kind of revolutionized the technique. Then you have 2009 Professor Jean Monod from the Swiss group who used it for the treatment of pain, and then of course Professor Andre Lozano from Toronto who used it for ET. The pilot study happened in 2011. Uh, After the pilot study, the FDA, US FDA first approved this technology for clinical use in 2016. Later in 2018, they also approved it for tremor dominant Parkinson's in the beginning, and then other motor features of Parkinson also, like rigidity bradykinesia. In 2022, initially they had only approved unilateral treatment. 2022, they did bilateral. 2025, July of this year, they approved treatment for both sides in Parkinson's disorder. Parkinson's disease. And now you can see that there are almost more than 200 centers in the world that offer. India, there are still only three, but of course there is great promise and great scope for expansion. Some of the prerequisites for this technology, of course, you need to have all MRI compatible implants in the body. Patient needs to be awake, alert, and cooperative. So probably not the best for pediatric age group or patients with claustrophobia or those other kind of things. The advantage of this, of course, is that you can keep clinically testing the patient while the procedure is going on. The patient needs to be able to lay down for 2 hours. A patient with severe lumbar problems or other back problems who have, you can't lay down, that's a big problem. Complete head shaving is necessary at the moment. In women, this can at points, at some time be a problem because women don't want to shave the head, so they might just, choose to remain with the symptoms. Absence of scalp disease, of course, if your head is immersed in a water bath, so if you have any infection or something of the scalp, if there is any metal plate in the scalp, that might be a problem. Skull characteristics, not all skulls are amenable to the transmission of sound. Almost 10% of people have skulls that are incompatible for this technique because of high density of the skull bone, and absence of any intracranial SOL. Of course, this is a relative indication. We have done patients with intracranial SOL, but usually it is advised not to do it because you don't know how the SOL might reflect sound waves, if it has calcium in it, or it might distort the brain anatomy in such a way that targeting might be difficult. Essential tremor, of course, we know it's one of the most common movement disorders. FDA approved it, MRGFUS for it in 2016, initially unilateral, then bilateral, and treatments are separated by 9 months to monitor for the development of side effects. The VIM nucleus of the thalamus is the usual target that is used. This is just describes the circuitry of the disease. What is important is that the dentatorubro-thalamic tract and its thalamic connections are what are important. We use this kind of tractography quite routinely to find individualized patient targets. This is a video of a patient who I was involved in the treatment of. And as you can see, severe essential tremor. This is the CRW frame that is fixed on the patient's head. As you can see, there is a silicone membrane around it to allow the water to be filled inside the hemispheric transducer. Now, once the patient is put into the MRI machine, all pressure points are padded so they don't get compression neuropathy. This shows how the 1024 beams all concentrate at the target. We are counseling the patient what he should expect on the table. This is us starting the actual treatments. Every treatment is called a sonication. During all these sonications, the patient is awake and being clinically monitored to see how much tremor improvement they are getting. And as you can see with subsequent sonications, the intensity, the amplitude of the tremor is going down. And once the patient and we are satisfied with the improvement, we take the patient off the table. This is the patient immediately post-op. As you can see, the tremor is completely gone from the treated side. The patient is, you can see the handwriting of the patient. This was before the surgery. This is after the surgery. So immediate dramatic improvements, able to drink water very well on his own without spilling. So it is an extremely gratifying procedure for the patient since it takes only about 1.5 to 2 hours and the patient gets complete symptom relief at the end of it. This shows the outcomes. Initially, we had outcomes at 12 months. You can see there is very significant reduction in the tremor score. So this kind of very well established efficacy. The side effects were transient because, as I explained, it is mostly because of the perilesional edema. You produce any kind of infarct or lesion in the brain. For the 3 or 5 days, it is going to cause a perilesional edema. Within 3 to 4 weeks, it should go away. So we had sensory side effects, usually cerebellar like dysarthria and ataxia, some gait disturbances. But most of these side effects go away, and at the end of 12 months, the side effect incidence is only about 4%. This is 5-year outcomes. This again goes to reinforce that it is not just temporary improvement. The improvements are very well, they last over a long period of time. And as I already described, we use tractography nowadays for target refinement. As you can see, four-track tractography has now become the norm. We usually use the area that is the intersection between the decussating and non-decussating dentate or rubro-thalamic tract as the ideal target. We also now have a number of normalization atlases which gather data from the treated patients and they superimpose that on the MRI of the concerned patient to help narrow down the hotspot. Parkinson's disease, huge problem, especially in India because there's a high incidence of young onset Parkinson's disease, almost a decade earlier than global averages. And given the population of India, I think we have a huge disease burden in our country. This is kind of shows the basic circuitry of the basal ganglia involved in Parkinson's disease. This helps us, narrow down the targets that we want to use. So, of course, we have the subthalamic nucleus, the VIM, which can be used, the GPI that we can use, and very importantly, what we call the PTT, the pallidothalamic tract, which has become a very interesting and target of choice for applications such as focused ultrasound now. So this is a close-up of the pallidothalamic tract. Of course, Dr. Gurmeet has also described this in a number of his talks. We use the Forel's field H1, as you can see. This is a conglomeration of the lenticular fasciculus and the ansa lenticularis, which are the output tracts of the GPI. So this is the pallidothalamic outflow tract. And targeting this gives the patient relief in all motor features of Parkinson's disease. So this is just a comparison of the various targets that we use in Parkinson's patients. We can use VIM in case it is tremor dominant Parkinson's. This was one of the first targets that was approved for clinical use. GPI, very well established for both lesioning as well as DBS procedures, mostly used for the non-tremor motor features of Parkinson's. But PTT seems to be a hybrid kind of target, useful in both phenotypes of the disease, that is tremor dominant, as well as akinetic and rigid Parkinson's. And it has the least incidence of side effects. VIM, as we explained, dysarthria, gait imbalance, paresthesias. GPI, we have visual deficit, speech gait, postural issues. PTT, there is a minor issue sometimes of slowing of speech, not necessarily reducing in volume of speech, but only slowing of speech. And if you go to medial, you can have gait disorders because of involvement of the internal capsule. But results so far are very, very good. Durability is a kind of a question mark because this is a newly instituted technique. As you can see, at 1 year, there is almost 80% reduction in UPDRS3 motor score. So excellent improvement. As you can see, like any pallidal target, the improvement goes on increasing as time goes by. So there is more and more improvement as time goes by, which is expected with a pallidal target. And recently, they have managed to publish long-term data as well for bilateral procedures. And as you can see, there is significant improvement. They have studied 40 patients now in an intention to treat analysis. And you can see at the end of 12 months after the second treatment, the improvement is still significant and persistent. Of course, it remains now to see even more long-term, durability of the results. But right now, at least, it seems quite it seems very good. Now, this is what we call a dual lesion. So, in patients who don't have complete suppression of motor features, they have now started to do a dual lesion. So, as you can see, there is a PTT lesion, pallidothalamic tract, and a VIM thalamus lesion. Both the lesions are done in the same sitting. It is quite possible, technically feasible to do this. And this causes almost more than 95% reduction in all motor symptoms on the table during the procedure. The Spanish group has a lot of experience in doing subthalamic lesioning. So they are doing unilateral and now they've started doing also bilateral MRGFUS, the subthalamic nucleus. There is some adverse
Sorry
effects
to
in the form
interrupt,
of
Dr. Niruddha.
dyskinesias.
You have
Sir?
last 2 minutes.
Yes, sir. I am almost done. So dyskinesia and some mood side effects, some hypomania, which are a little worrying, but the results seem very promising. And as can be expected with a subthalamic target, the tremor reduction is very, very significant. Numerous emerging indications. Dr. Devgaonkar has spoken a lot about these. So basically, the idea is that a lot of disorders in which you already do lesioning procedures and you have good outcomes, you can convert that into a completely non-invasive procedure. So we have obsessive compulsive disorder. This is very, very close to getting approved. Already 40 plus patients have been studied, excellent outcomes. Major depressive disorder, results were not considered statistically significant at 1 year, but at 2 years, they started to reach significance. As Dr. Devgaonkar said, long-term studies do show a good benefit of these procedures in depression. Chronic pain, as Sir said, cingulotomy, thalamotomy, even mesencephalotomy have been done. Excellent outcomes, but better mostly in upper body than lower body pain syndromes. And epilepsy, mostly we are only doing ablation in focal epilepsy. So kind of limited outcomes, but if you consider diseases such as hypothalamic hamartoma, we see very, very good outcomes. A number of clinical trials still going on to find out new indications and also kind of refine the existing procedures. Limitations, of course, are that in India, especially, the cost is very high, needs head shaving. You get limited number of sonications because the skull bone, as I said, is not very good at transmitting sound beams. We have a limited zone of activity with the current design of the device. We can mostly treat deep brain targets, but not surface of the brain. And it is a little difficult to apply in non-cooperative patients, such as pediatric patients or patients who have claustrophobia. So in summary, HIFU or focused ultrasound ablation is a safe, effective, minimally invasive procedure, very suitable for deep brain targets. World is your oyster. As I said, you think of a target, you think of an abnormal circuit, and you can treat it with this technology. Numerous studies are underway. It is under investigation, and cost remains an issue in health systems such as in India. I thank MCNS for giving me this opportunity, and I thank all the listeners for being patient with me. Thank you.
Yeah, thank you so much, Dr. Niruddha, and all the speakers. So, along with me, we have co-moderator Dr. Datta Muzumdar, sir. Sir, may I request Dr. Yamamoto to have his remark on the topic? Dr. Yamamoto? Yeah,
And
please
thank you very
share
much
your
for
experience
all
with
the
you.
topic. Sure, sure. So, thank you very much for all the topics of the presentation. All were amazing and very important topics. I was kind of surprised the high incidence of young onset of Parkinson's disease in India. I have a comment here regarding focused ultrasound. Um, so the last speaker mentioned GPI, pallidotomy with focused ultrasound, but um, uh, The study was published a couple of years ago. The RCT focused on targeting the GPI to treat Parkinson's disease. And then, RF lesioning for Parkinson's, GPI pelviectomy for Parkinson's disease works very well. But just because of the nature of focused ultrasound, it is very hard to target the lateral structures in the brain. So GPI targeted is located approximately 20 to 21 millimeters lateral to the midline. So that's why it is very difficult to get a high temperature in the target in GPI. That was the reason probably for the failure of the study. The study demonstrated that the GPI pelviectomy with focused ultrasound is not a very, very good treatment for Parkinson's disease, and probably for dystonia as well, which haven't been studied yet. But PTT is, as you mentioned, also a good target with RF lesioning. And PTT is a very good target for focused ultrasound because it's more centralized, and that target is between 9 to 12 millimeters from the midline. So it is very much easier to get a high temperature in a PTT target. So in the coming years, I believe PTT autonomy with focused ultrasound will the number of it will be expanding worldwide, and it's been already approved by the FDA for Parkinson's disease. And on my experience, and even with even for bilateral procedures, staged bilateral, and based on my experience, PTT autonomy is a very good target for treating dystonia as well.
Yes.
So PTT autonomy for dystonia will be the next target for FDA approval.
So actually, a lot of people use PTT for proximal dystonias, and they kind of expand it to the VO for distal dystonias. And those targets are very close, and they can be targeted in the same treating session. So in fact, the great advantage of MRG FUS is, unlike RF, you don't need to do multiple entries, and you can geometrically shape the target into any kind of volume that you want. You can overlay lesional spots on each other to produce rounded, straight, curved lines, whatever you want. Any kind of shape of the target can be achieved to cover numerous areas.
Okay, yeah, very good point. Yeah, you're right. Some patients have, especially with large, relatively large ventricles, it is a little bit hard to target the PTT in the same from the same entry, because the VO target is usually located approximately 15 millimeters lateral from the midline, compared to it's more lateral compared to PTT target. But focused ultrasound is very promising because it's easier to target both targets in one patient.
Yes. And we are not trajectory limited, unlike RF.
That's right. Exactly.
Yes.
Thank you very much.
Good. Thank you very much. We are fortunate to have a neurologist with us, and all this movement disorder patient comes from a movement disorder specialist. So we'd like to listen from neurologist's perspective, ma'am, about the indications of surgery and your experience. How is the outcome?
So, thank you for inviting me to be a part of this very interesting session. And yes, as a neurologist, I would have one concern regarding patients with Parkinson's and dystonia with bilateral symptoms, not the tremor dominant ones. So I would still like to offer DBS as the first option to them, because I would have a concern regarding the progression, because the DBS is a titrable option, whereas the lesioning, what if the progress after a few years? So I would also like to discuss this with the
Indeed.
speakers about their experience. Like, if they progress, can we lesion again? And especially if we have done bilateral lesioning, or can we do DBS after the initial lesioning in the same targets? So those would be some concerns that I would have in mind. So, like, from my experience and comfort level, I would prefer to offer DBS unless they are not willing for DBS, or they don't want they want a minimally invasive option. So I would also like to discuss about this with the speakers, especially Dr. Anirudh and Dr. Sawhney, sir. So
Yes. So,
Gurneet sir, may I go first, sir?
Yes, please. Yes.
So, Dr. Pillai, in my experience, I mean, I usually kind of separate patients into two groups. Is it a progressive disorder or is it a static disorder? If it is static disorder, a lesioning procedure has a good chance of success. If it is progressive disorder, neuromodulation has a better chance of success, such as DBS. And quite rightly, as you said, in diseases like Parkinson's disease, we definitely would prefer to have a titratable therapy. That being said, the outcomes of DBS, outcomes of lesioning procedures such as PTT lesioning have shown a great promise in the treatment of all motor symptoms. We are still monitoring the long-term data, so it's not like we have the long-term data. We are still monitoring it. And as you rightly mentioned, after doing a lesioning procedure, can you lesion again? The answer is yes. We have done this in the past. So as I said, we are progressing more toward tractography based targets rather than anatomical targets. So if you do a tractography again and you find, the remnant of the tract, or you find another lesion you can target, you can go ahead and do a HIFU or RF lesioning one more time. Secondly, having had a previous focused ultrasound or RF lesioning does not preclude the patient to getting a DBS procedure. So if that is a concern, they can always go and get a DBS in future. This is always possible.
yeah. Sawhney, sir,
Yes. So, Dr. Anirudh has covered all the points of what Dr. Kanchana had asked. A little more on that is that if so for a patient with Parkinson's, a DBS is still the preferred option, as it is a progressive degenerative disease. But yes, in India we have got so much of patients who are not affording to that level, and then if they don't receive the treatment, they land in trouble. So it is better to give them something than not give them. That will give rise to more of a problem, as we have seen this. Secondly, we also the pallido-thalamic tract is very promising for both HIFU, as we have seen. The interesting part is that bilateral lesioning for Parkinson's is also approved in this year, that is in 2025. What we need to see is whether they are doing it simultaneously, or whether they are doing it staged. Is what
6 months, sir.
6 months. So 6 months in the same target, or a different. That's also something. So when we are using a pallido-thalamic tract on one side, then opposite side we would prefer a GPI, not the pallido-thalamic tract.
No, they don't bilateral
Dr.
PTT, sir.
Can, can I ask you about this? What is your experience about bilateral thing? Dr. Kazuaki Yamamoto, can you hear me?
Yeah, yeah, I can
Yes.
hear, but I couldn't
Yes.
hear my name. Okay.
Yes. So
Okay,
for
yeah.
bilateral,
So
or
actually, yeah, I've treated many patients with PD with staged bilateral PTTotomy. I never do GPI pallidotomy anymore because of the high incidence of the high risks of delayed infarction following GPI pallidotomy. It's approximately 5%, which is not acceptable to me at all. So, but in contrast, after PTTotomy, it never happens. And after staged bilateral PTTotomy, the outcomes are usually excellent because I screen all patients, involving including level of the challenge test. I always check the deeper responsiveness, as you mentioned. in your presentation. And but I rarely I've encountered a few complications, permanent complications, including hypophonia and micrographia, but that's it. A few cases. And the stage of bilateral PTTotomy, I don't think it's dangerous.
So one of my patients with PTT had hypophonia, and that stayed for about 3 months, which I was actually worried that this would stay for long, but it recovered. Now he is for the opposite side, and I'm thinking that first side gave me hypophonia. Should I do the opposite PTT? Because it should not happen that he has hypophonia permanently. Does that happen or it doesn't?
Could happen. So hypophonia is still disabling. Might be disabling in his daily life, but what if he encounters hemiparalysis after delayed infarction? Or it'll be a disaster. And delayed infarction after pallidotomy. It's sometimes severe hemiparalysis and disastrous and very, very disabling in patients' daily life. So I wouldn't do that anymore. In the past I did, but I never, fortunately, I never encountered a delayed infarction. But the literature suggests that approximately 5%, which is not acceptable. So I prefer PTTotomy.
Yes. Okay. Thank you.
If I may make a comment, sir, if you have done the RF on one side and you're planning the second side, as you know, a PTT we separate into medial and lateral, and we do two separate lesions on those. So if you try to avoid the medial PTT and only do the lateral one and then grow it into the VO, that might be a strategy to consider, sir.
Okay. So for growing it to a VO, we need to have a high flow. Yeah.
Many of our neurosurgeons are not practicing this exclusively, and many are interested in knowing the role of DBS in traumatic diffuse brain injury. Is there anyone having experience, and how is the outcome of DBS in diffuse brain injury?
So, can I answer this? So,
Yeah, please.
So this I rushed through. Uh, can I share one slide which was there? Is it allowed?
Yeah,
Just
I remember we saw that last slide.
last slide, which
Yeah.
I did not do this. Give me just 1 minute. Let me just
Please share.
share my window. So just share. Just one. Okay.
And when do you advise it, whether you wait for 3 months, 6 months, or a year, and then you advise DBS for such patients, because there's a natural course of recovery, and after a certain time you feel that the recovery is halted, and that point of time you advise?
Yeah. For this case, this was a child of 2 years, had a diffuse axonal injury, and he was in the hospital, and when I went to see this patient, which was by chance when I was speaking, this was in interior Maharashtra, where we found that the patient has got what is called status dystonicus, which was probably not identified before. And this was a clear case of status dystonicus because of diffuse axonal injury that the patient
The
had.
slide is not seen, Gurneet.
Oh, I'm so sorry. Oh, it's not seen at all?
I
1
can
minute.
see your screen, but it's a home page, I guess.
Oh, okay. Wait a minute. Let me screen it again. 1 minute. So I will stop share this and again share it again. Wait a minute.
Okay.
Allow to share. Allowed to share window or screen? I should say allowed to share screen.
Screen, sir.
Yeah.
Screen. Allowed to share
Right.
screen. Sorry. So share entire screen. Can we see now?
Yeah,
Yes,
yeah,
sir.
you can see now.
Yes, yes. So, so when I went to see this patient was approximately 1.5 months or 6 weeks after the injury, where the patient was tracheostomized and they were waiting with. So all the other tests for ruling out status and things were all done, and here when I checked it, so he had status dystonicus, which we can see. He is completely arched. All the legs are stiff, the hand and shoes. So when I'm moving, so this patient, I did a bilateral palliothalamic tracheotomy, and this was immediately post surgery, where we see that his tone had come down. He's straight, as we can see. He's his movement of the legs, the tone is better, and he for the status he improved. He did not. So from the diffuse axonal injury picture, he did not improve. He took his time, as the DI takes, but uh, the other comorbid which was there. Now let me stop the screen share. Yeah. So other the morbidity which was happening because of this status dystonicus, that had gone, and the patient was able to get rehabilitated faster. So so for this, one of the conditions which I did, but I would really like to ask Milind sir.
Yeah,
Milind
sure,
sir,
sure.
exactly what sir wanted to say, sir, about this. What do you feel?
I mean, as I was talking in the thing, we did this trial way back about mm, DBS in traumatic brain injury. And we included patients with minimally conscious state. So these patients with minimally conscious states are the patient which will open eyes sometimes, will not have a useful communication, will have sleep-wake rhythms. And we waited, the longest was 18 years after injury, and the shortest was 6 years after injury. So I would like to wait for usual course to go before we start doing anything. So maybe 9 months, 12 months. And for selection criteria, one of the criteria was that the thalamus has to be intact. So we need both thalami intact. The second criteria was we used to do functional MRI scan in the trial, and after that also a few DBS that I've done in OSU. You do a functional MRI scan and see the activation. Is the only primary sensory area activated or associative areas are activated? So we had visual protocol and auditory protocol. So in visual protocol, we'll just show the pictures of unrelated people and then wife's picture or son's picture. So related. So when they show the familiar pictures or hear the familiar sounds, not only primary sensory area is activated, but also the secondary areas, associative areas. You see supramarginal gyrus activation, you see hippocampal activation, you see cingulate activation. That basically means your brain networks are intact. Only there are islands which are damaged, and those are the patients where DBS can be useful. As against this, when there is anoxic brain injury, everything is wiped out. So doing a DBS in anoxic brain injury is a big no-no. But in traumatic brain injury, whether it's persistent vegetative state or minimally conscious state, I think the criteria for selection is to see if the brain networks are intact. And the only way to see nowadays, you can even do DTI and bold fMRI scans. But that time there were just first generation fMRI available, so we did this auditory and visual protocols. And again, the stimulation parameters are unique for this. We had response about 33 hertz. And that's thalamocortical frequency.
Shyam sir.
I think that's the thalamic frequency in multiple of 3. So 33 hertz we used to stimulate and had good response. Those 4 patients in that trial, and we've done about 6, 7 more after that. I've done one in India also way back in 2010, 2009, 2010. In properly selected patients where the family is willing to go to the last mile and they have insurance or corporate payment, I think the family knows this is the experimental procedure. I think this is a good way to go forward.
Yeah, thank you, sir. There's a question for Milind sir in the
Sir,
chat box.
sir, what target do we take? I'm sorry. What target, Milind sir? What target do we take?
We targeted intralaminar nuclei. Basically, we targeted CMPF. So centromedian nucleus, mostly centromedian part of the CMPF complex. So the intralaminar nuclei, whether it's a nucleus centralis, lateralis, or centromedian parafascicularis, these are tall nuclei. They go up. So we used to put that 3821, the longer lead with 1.5 millimeter in between. So we get a good tall stimulating thing going. So I think intralaminar nuclei are very interesting because they are part of arousal. Francis Crick, who did the Crick and Watson's DNA model, worked on intralaminar nuclei, called it the cave of the brain, which we don't know much about what they do. And these patients were very interesting. I mean, some of these patients after the IL DBS had changes in their temperature perception. Normally, when they were not feeling cold, they started feeling cold. Some patients had these weird things. They used to tell us that this is happening because we used to do outside stimulation for 2 weeks. They used to be in EMU and we'd stimulate in EMU, basically matching the with the surface electrodes, basically trying to match the thalamic frequency. So intralaminar nuclei is the target. You can do CL also, but we used to do CM. CM has the most connections all over.
So Milind sir, there's a question for you in the chat box. So after DBS for depression, can patient be drug free, or to what extent the patient's need for the drug is reduced?
On an average, you see about 40% reduction, but there is selective reduction. So major benzodiazepines and antipsychotics, they are reduced down to 0. Anti-anxiety and minor anxiolytics, they still have to continue. Probably I've seen maybe 1 or 2 patients which completely went off drug. The problem with depression is you might make their frontothalamic outflows more active, but they still go back in society and they still face the day-to-day stresses of life, work. So they end up on some kind of anxiolytics. So yes and no. I've seen people off depression medication, but on an average, about 40% reduction.
And the same question is for Parkinson's as well. After DBS, does patient need dopamine supplements or any drug treatment, or that is also reduced to minimal extent?
People going completely off the anti-Parkinson medication are uncommon, not rare, uncommon, but they do go off completely off Parkinson's medication. Mostly young onset PD. Young onset PD patients will go, and tremor dominant PD will go off medication completely. But later on, as the disease progresses, they will need it at some point. And again, you see about 50 to 60% reduction on an average in anti-Parkinsonian medication in normal Parkinson's.
And there's a question from the audience, like they want to know, as the treatment is so expensive, can poor afford this treatment in under any kind of Ayushman Bharat or any government scheme? Is there any such provision?
Not for
So
DBS, as I know. Maybe Gurneet knows more than me, but I don't think there is any scheme.
CGHS gives 14 lakhs for the battery, but the rest of the
Oh.
cost has to be given by the patient.
Oh,
Otherwise, they
yeah.
can apply for funds like Tata and.
Okay, I'll answer this.
Yeah.
So some of my CGHS ECHS, State Bank India. So they have given complete full packages. Secondly, secondly for so it's government of Andhra, Telangana mainly. They provide the funding for DBS. So in Nizams, when they are doing DBS a lot, it's all funded. They are so if it has happened in one government, in one state, then it is all likely that things can move forward, and people realize this. Having in Ayushman Bharat, DBS will be a little difficult, but if they can cover lesioning procedures also, because Ayushman Bharat doesn't even know that there is lesioning procedures happening. So
Okay.
even if they cover lesioning procedure, 5 लाख के अंदर भी अगर जो भी
Okay.
है,
As a question for
अगर
Dr. Yamamoto,
things
if we
things
compare,
can happen and things can move.
then
So
this
for
is-
patients who cannot afford DBS, lesioning are done in a
okay,
very there is not there.
yeah. So question to Dr. Yamamoto, if we compare DBS, focused ultrasound lesioning and RF lesioning, so overall, what is the picture with regards to outcome in Japan?
So, regarding this question, probably, so in the question, there is no specific disorders mentioned. So, there have been studies comparing DBS and radiofrequency ablation for PD patients. But the most famous one is an RCT that compared DBS and RF for PD in 2000, around 2000. Uh, but the method was kind of old, and there was no assessment scale at the time. So the results were assessed like poor, excellent, or good, or something like that. So it was kind of subjective, and but nowadays we have specific scales, scales such as specific disorders like MDS, PPDRS, or clinical rating scale for tremor. So, you know, most of studies have compared those modalities, but basically they were not direct comparison, but they were rather meta-analysis or review papers. So there have been no direct comparisons in RCT, and it's not only in Japan but worldwide. So people have to choose modalities considering the all the pros and cons of each modality rather than the outcomes shown in RCTs. So, but to the outcomes, it says. So already, like some people have already mentioned, Parkinson's disease, for example, is a progressive disorder. And essential tremor could also progress over time, but it's very, it's very related to age. But lesioning procedures are very good for essential tremor, but because the progression is usually mild, and after lesioning procedures, the long-term outcomes are usually good. But for PD, in my philosophy, I also consider BDBS first because it's a progressive disorder, and we can adjust the parameters, stimulation parameters for those patients if it's progressed over time. It's one of the advantages of the DBS. So we have to offer all the modalities, explaining all the pros and cons of each modality to patients. I do so to all my patients, and patients choose. So I wouldn't choose, but my patients choose which modality to go with.
Right. Thank you so much. The webinar is becoming quite interesting. So,
Hey, Sandeep, can I
yeah.
just chip in?
Yes, sir.
I think what Dr. Yamamoto said is very right. Patients have to choose, but we are in the age of personalized medicine. So it's a personalized neuromodulation plan. So it depends on patient's age, depends on patient's financial status, it depends on patient's comorbidities. And then you can tell them that these four options are there: gamma knife, RF, HIFU, and DBS. And you can tell them what is better for you, and then they can choose otherwise. I mean, people who undergo CABG and stenting, it's the same kind of logic here. Patients who don't want to have invasive surgery, they don't really care what happens after 20 years. I think those can be treated with non-DBS modalities. But younger patients who have very less comorbidities, I think DBS is the first thing. Now, patients with blood dyscrasias, hematological abnormalities, which cannot be corrected, I'll rather go for gamma knife. So, I mean, you can decide per patient. Otherwise, outcome-wise, I think all the four modalities are more or less the same for immediate post-intervention outcomes. Long-term outcomes are different in all of them, but then you put that in front of the patient, and then patient has to choose. So you can personalize the neuromodulation according to the patient wish and according to what is going to happen in next 20 years.
Right, sir.
And if I may just add a comment here, efficacy is quite almost the same in all, except for the cognitive outcomes. Cognitive outcomes universally have been shown to be superior in MRGFUS, probably because we are not disrupting the frontocaudate affective circuits. So that is one very important thing about MRGFUS, that it doesn't produce the typical cognitive impairment that you see after lesioning or DBS procedures.
Okay, right. Thank you. So, Dr. Mujumdar, sir, is there? Sir, your remarks?
Yes. I was
Well,
listening to all the things, but I think it is a fantastic experience. My only thing is that nobody's talking. Are there any side effects or complications that need to be worried? Because ultimately, high frequency ultrasound you are using to the brain, you are listening. So, is there something which the patient needs to know in the immediate short term or long term? We are talking about the gratifying results, yes. But all these things, all these patients are very morbid, and always there is a cost involved. There are certain things where you have to do repeated procedures. So we were talking about PTT lesioning, this thing first, and then they can go for RF, they can go for this. So these things also need to be addressed as when we are talking to a general audience. So cost, multiple procedures, choosing the million. Dr. Devakar had just mentioned about how to choose the procedure, but yes, side effects, those needs. I think I'm sure that RF and this thing must be having something which can the speakers elaborate on that, or there are no side effects.
Sir, I've just shared my screen. I don't know if you can see it.
Yeah.
Yeah, I can see.
So this kind of shows the adverse effect with MRGFUS procedures done in PD or even for ET for that matter. And as
Hmm.
you can see, there are known side effects, sir, of all procedures. You will find that these are quite similar in both, DBS, RF, and MRGFUS. The difference between lesioning and neuromodulation procedures are that if you get adverse effects on table while doing the procedures, there is high
Hmm.
likelihood that it will be a permanent side effect in lesioning procedures. In DBS, because it is reversible, there is a chance that if you reduce the stimulation parameters, the side effect will also disappear. Having said this, with the advanced kind of targeting that we do using tractography, normalization atlases, and all those kind of things, and in MRGFUS, we initially do a low energy sonication to produce only a temporary effect. And once we are sure that we have good efficacy and no side effect, then and only then we go and do a permanent lesion. It is the same as in RF also. We initially only stimulate a little and then we do the permanent. So there is that level of safety. The third, but of course, everything included, a lesioning procedure will produce usually permanent side effects if it happens during the procedure. Now, if you get side effects after the procedure, it is very likely to be because of perilesional edema rather than the lesion itself. And so that is always expected to disappear in usually 3 to 4 weeks. And you can speed it up with the administration of oral steroids. And the last point I've already made, that in MRGFUs, because you don't interrupt the white matter tracts of the brain, cognitive outcomes have been seen to be better than with open procedure.
Yeah. So in case of lesioning, what are the incidence of developing permanent deficits?
So in MRGFUs, at least I can speak that paresthesias, dysarthria, we've seen almost 4% incidence of persistence of these side effects at 12 months. And with bilateral procedures, if you do with a patient who already has this kind of deficit, it can go up to as much as 15%.
It's too high.
Okay. I think that sums up all. I think it is a evolving field, and I think there's a great future for this in the coming times, and we are at the right time, as what Gurmeet just said. Maybe these government schemes will have to be educated for incorporating this into the Ayushman or the this thing, because otherwise there are so many patients who are left untreated. And maybe some of us would take it at the government level, or in the municipal or the government level, to get it sanctioned, because otherwise, as you see, the programs in government and municipal hospitals start and they don't sustain. As of now, I don't know any government or municipal hospital having a sustainable program. Most of the programs which are done are in the private sector or the corporate sector. So that one thing which Gurneet has mentioned, maybe the patient can get benefit. No, all the patient has a good chance to choose. So the private sector also can get benefit out of this, as well as the government municipal hospitals also do get benefit of this. But it has to be, I think, put in the proper perspective to these people.
So, sir, AIMS New Delhi has acquired a HIFU machine recently. It is
Yeah.
not yet operational, but they have acquired. So let's see how.
But as you know, AIMS gets it before the parliament budget. So
Exactly.
anything AIMS, the same cannot be said. We have tried. As you know, KEM had started
AIMS is a different
movement
ball
disorder
game.
program. Yeah. No, I'm telling you, KEM had started movement disorder program for 3-4 years, but it was not sustainable. That was 20 years back I'm talking about. So it was a tragedy actually. So I think, but we have more of awareness now amongst the community, and I think MCNS also is a good platform to showcase this. Functional is
Right.
the way forward now. So in fact, it might come in more into epilepsy also, and more and more lesioning of DBS for epilepsy is also getting momentum. So I think we have great speakers and great panelists, and thank you all for this
So
thing.
there's a
So
last
over to Sandeep.
question from
Thank
our
you.
secretary, Sarang Rote. I would like to know what TMS. Can make a short comment on TMS?
TMS is good for depression. I mean, it's FDA approved for depression. TMS is also good for Parkinson's and tremors. The effects are, there are carryover effects, but they are temporary, short lasting. And it can be used just in as addition to medicines in those patients, but TMS is not permanent. So TMS is something like a medication which will last for some time. So
Yes, absolutely. It will take. So it is a procedure which can be done easily, repeatedly, but sustainability is not there because there's no permanent thing on that. Yes. Yeah.
Yes. Thank you.
Yeah.
Thank
I think it's 10 o'clock, and if
Yeah.
there's no more question or comments, can we conclude with the permission from Mazumdar sir?
Yeah, I think we should thank all the speakers. I think
Yes, sir. Yeah. First
fantastic
of all, I would like
panelists.
to thank Dr. Yamamoto, who has taken a time in the middle of night and is available for this such a wonderful webinar. Thank you so much, sir. And I would like to thank Dr. Kanchana Pillai, on her wedding anniversary, she
Oh,
could
oh,
spare
yeah,
and Christmas Eve. She's
Wedding
available for us.
Very nice.
Thank you so much, ma'am.
yeah.
And
Yeah.
thank you,
And we
Milind
have,
Devgam.
as you know, Dr. Devgavkar is local guy, but he has got a huge international experience. So somebody
Yes, sir.
staying abroad for 20 years and coming back to India is
Yes,
also
sir.
an
And
so,
this webinar was designed after discussing with Milind sir only when recently I had come to
yeah,
Nagpur.
yes,
And
yes.
so we had a discussion about
Yeah.
this DBS in traumatic brain injury. And then we thought, why can't we conduct a webinar on this topic itself? Thank you so much, Milind sir, for your valuable inputs, your valuable time. And thank you so much, Dr. Gurneet and Aniruddha, for making this
Thank
webinar wonderful.
And
And
Shiv
thank you,
Shankar also, very,
MCNS.
very Shiv Shankar. Shiv Shankar is the
Shiv
backbone.
Shankar.
Yeah, sir. Good
Yeah.
evening.
Yeah.
Okay. Okay. Well, Merry Christmas to all
Okay.
and have a good,
Yeah.
good
Merry Christmas to
Good
all.
night.
See you,
Yes.
Professor Mujumdar, after such a long time. And
Yeah.
Christmas to all. And from all of us, happy wedding anniversary to Dr. Kanchan.
Yes.
Absolutely.
All of us. Yeah. Okay.
Yeah.
Thank
Yeah.
you.
Thank you.
Dr.
Thank
Sandeep,
you.
thank you, Milind
Oh,
Devgankar sir,
thank
for
you,
it.
madam. Thank you so much, madam.
Thank you. Happy wedding.
Thank you. Thank you. Good night.
Okay. Thank you.
Good night.
Thank you. Good night.
Thank you, Dr. Shiv Shankar.